Within 10 years, the job you're training for may not be the scary part. The scary part is that medicine will stop waiting for you to get sick. And that one change will quietly decide who gets funded, who gets hired, and who gets trusted. If you're building a career around episodic care checkups, diagnoses after symptoms, treatment after decline, your value starts shrinking the moment continuous detection becomes the medical baseline. But if you understand the loop, you can ride the wave instead of getting crushed by it. Continuous detection is exactly what it sounds like. Systems that monitor your health signals in near real time, then flag risk before a crisis is obvious. Not a test once a year, but a living stream of data from wearables, smart patches, home sensors, and lab-grade assays that can be repeated automatically. The breakthrough isn't only collecting signals. It's interpreting them fast enough to matter, turning messy physiology into decisions while the window for intervention is still open. Here's how it works in plain terms. Your body produces patterns, heart rate variability, glucose trends, inflammation markers, breathing stability, sleep architecture. Models learn what normal for you looks like, then detect small changes that signal the early stage of disease, stress, or recovery failure. That drift is not a diagnosis by itself. It's a risk alert that tells clinicians and systems where to look sooner with less guesswork. The clinician becomes less of a detective who waits for evidence and more of a manager who continuously calibrates trust in the machine's alerts. This rewiring hits careers first. Roles that depend on delayed diagnosis, manual scheduling, or periodic testing alone become less central. Funding follows the demand for speed and prevention. So startups and hospital budgets shift towards sensor platforms, model validation, and workflow integration, especially the boring parts that make detection usable at scale. Data governance, cybersecurity, and clinical evidence move from supporting topics to core profit centers. Because continuous detection creates continuous responsibility. It also changes trust, and trust is where the friction lives. If a device flags something and nothing happens, patients lose confidence. If it misses something, liability can spike. The winners will be the teams that prove accuracy across real populations, handle uncertainty transparently, and make the feedback loop meaningful. In practice, that means combining device data with clinician oversight and periodic confirmation, while steadily improving the system's sensitivity without drowning people in false alarms. Now imagine how quickly this spreads once it works. Hospitals adopt it to reduce emergencies. Employers adopt it to reduce absenteeism. Insurers adopt it to price risk earlier. And individuals adopt it because it feels like control. The next standard of care won't be a new drug. It will be the promise that the system notices you before you notice yourself. And when continuous detection becomes normal, the real question isn't whether you'll be monitored, it's whether your career, your business, and your credentials will be built for the world where waiting is the exception, not the plan. Within 10 years, the job you're training for may not exist. And that is not the scary part. The scary part is that the skills you thought were optional will become mandatory overnight. Continuous detection is how medicine gets there. Sensors that watch you, biomarkers that signal risk, and real-time inference that turns raw data into clinical meaning fast enough to change decisions while there is still time. It starts with capture, because continuous is a hardware promise. Wearable patches, smart beds, implant-adjacent devices, and bedside monitors measure signals like heart rate variability, oxygen levels, temperature, glucose proxies, respiratory patterns, movement, and sometimes biochemical markers through microfluidics. The data stream doesn't look clinical. It looks like numbers with noise. Your body is dynamic, sensors drift, and readings vary with motion, skin contact, and environment. So the system first cleans the signal, corrects artifacts, and estimates baseline what normal for you looks like in the current moment. Then comes transformation. Biomarkers become detectable features. A biomarker can be a molecule in blood, but it can also be a measurable pattern in physiology that correlates with disease processes. Machine learning converts the stream into features, trends, rates of change, variability, and event signatures, then compresses them into something a model can reason about. Instead of waiting for a lab test, The system infers risk from the way your signals evolve over minutes or hours, not days. The key is that inference is not guessing. It is calibrated prediction, trained on historical records where clinicians labeled outcomes. That's where real-time inference earns its name. A model runs continuously, producing risk scores or probability bands for specific clinical states like deterioration, exacerbation, sepsis likelihood, or arrhythmia risk. Clinicians get outputs they can interpret, not just a number, but thresholds, confidence, and recommended next actions tied to workflow. In plain terms, the model learns which patterns usually mean trouble, and it updates the estimate as new data arrives. But continuous detection only works when it's clinically safe under uncertainty. Real-world signals are messy, so the best systems track uncertainty, detect when the sensor is unreliable, and avoid false certainty. If the input quality drops, the model can downgrade confidence or request confirmation. That is critical for trust and for liability. A device that alerts without context can create panic, while one that hides uncertainty can create dangerous silence. The winning design treats uncertainty as part of the interface, not an internal detail. Finally, the outputs must land in the care loop. The system integrates risk alerts with patient records, staffing rules, and escalation protocols, so the detection becomes an action that humans can validate. Continuous detection is less about the sensor alone and more about the pipeline. Capture, signal processing, model inference, evidence tracking, and feedback. In other words, it turns medicine into a living data set, constantly recalibrated by outcomes. And once that pipeline proves itself, the next breakthrough isn't a better sensor, it's a better feedback loop. What happens when the model doesn't just detect risk continuously, but learns from every confirmed outcome as it goes, week after week? Within 10 years, the clinic visit you're used to may become optional, and that's not the scary part. The scary part is who gets the power when health becomes continuously detected. If you can spot problems early, you can prevent harm. But if you can measure everything, you can also control decisions. The upside is fewer emergencies and better personalization. The downside is new forms of surveillance, new costs, and new failure modes when alerts don't translate into care. This is where the disruption starts, not with a wearable on your wrist, but with the operational shift from episodic care to continuous monitoring. Instead of waiting for symptoms, devices and home tools stream signals like heart rhythm, oxygen levels, glucose trends, sleep patterns, and medication adherence. The system turns those signals into risk estimates in near real time, then routes them into the place where decisions happen. The clinical workflow, not the user's imagination. Patients are the first disrupted because their identity becomes data. People who once reported how they felt now get ongoing feedback, sometimes subtle, sometimes urgent, that can reduce anxiety when trends are explained. But it can also create chronic worry if every fluctuation becomes an alarm. Continuous detection forces a new kind of communication. The system must say what it knows, how sure it is, and what to do next. Otherwise, patients either ignore warnings or overreact. Clinicians are disrupted because their work shifts from calendar-driven tasks to exception-driven oversight. Monitoring programs can prevent missed deterioration, but only if clinicians receive evidence they can trust and act on quickly. If alerts flood inboxes without clear context, clinicians will override them or the system will lose credibility. The best setups compress friction by attaching each alert to patient history, device quality, and escalation rules. So the clinician isn't hunting for meaning. That changes training, staffing, and even how care teams define being available. Insurers are disrupted because continuous detection changes risk pricing and claim timing. When you can track adherence and early warning signs, you can shift from paying for outcomes after harm to rewarding behaviors that prevent harm. That sounds fair, but the tension is contract design. Who owns the data? Who benefits from lower premiums? And what happens when alerts are tied to coverage? Device companies are disrupted too, because the value isn't just sensing, it's managing the whole detection pipeline and proving it works across populations, environments, and device work conditions. A sensor that's accurate in a lab can become unreliable in real life, and the product must handle that uncertainty continuously. Home labs and remote Ops extend the system from where and forget to test and decide. Small diagnostic devices at home can collect samples, run analyses, and stream results back to care teams, turning the home into a temporary extension of the clinic. That reduces travel, speeds intervention, and shifts logistics toward orchestration, shipping supplies, scheduling remote review, and coordinating follow-up. It also raises practical questions. How quickly a change in status triggers a response. How remote triage avoids both neglect and overtreatment. And how safeguards prevent misuse of automation. The operational heart of continuous detection is the feedback path. Every alert should be connected to an outcome. Did the patient truly deteriorate? Did a change in treatment help? Did the device quality explain the signal? And did the model learn from what was confirmed? That is how medicine becomes a living dataset, constantly recalibrated by outcomes, not just recalculated by new inputs. And the next shift is already hinted at. When systems can learn from confirmed results over time, who will be able to turn that learning into better care? Faster than current rules and incentives can keep up. Continuous detection, ISNT, just about sensing more. It's about closing the loop between signals, decisions, and outcomes. So alerts become action instead of noise. The winners will own the full pipeline. Continuous quality control, trusted feedback, and contracts that keep data rights and incentives aligned. Lose that, and you get surveillance with weak safeguards and incentives that reward alerts over healing. The future arrives fastest where learning is confirmed, audited, and used responsibly. So here is the question. Are you designing systems that earn trust through outcomes, or just collecting data that can't prove value? Watch the signals, then act. Audit your plans, pilot responsibly, and get ready before the market makes the choice for you.